Good afternoon, ladies. Hope you guys are all doing well. I know that the last chapter has been a little challenging, and I just want to say you guys are all doing a great job with the considering the circumstances and the limited resources. Just know that you guys will be given credit for your effort in searching for the diagnosis codes in Chapter 18, as well as searching for the CPT codes in Chapter 19. So we're going to wrap up this class with chapter 17, and chapter 17 is basically just insurance and billing. Okay, so we'll go over the different terms used by the insurance companies and in the insurance industry as a whole. We'll discuss the differences between fee-for-service plans, your HMO plans, PPO plans, and then of course understanding the new concept of patient-centered um, medical home, and also just the medical care provided. We'll discuss the key requirements for coverage for both Medicare and Medicaid, as well as other government plans such as TRICARE and CHAMP VA programs. We'll also discuss allowable charges, contracted fees when it comes to contracted fees with the insurance companies, between the insurance company and the provider, what a capitation is, and then we will also discuss the different types of the HCPCS forms as well as the electronic version. The HCPCS form is the paper version, and then they have the electronic version as well. And then of course we will also discuss what is called the RBRVS, which is just the formula used to determine reimbursement rates according to Medicare and other insurance guidelines. Okay. We'll also discuss what information we need to include when submitting an insurance claim, how to produce a clean Center for Medicare Services 1500 health insurance claim form, which is basically the HCPCS form. We'll talk about different methods used to submit insurance claims electronically, like I mentioned before. And then we will go over the information that we would find on every payer's remittance advice. And I have a form that you guys can, excuse me, yeah, I have a form that you guys can preview to see what that all entails. All right, so just some basic insurance terminology that is beneficial to know, that helps to understand when you hear these terms out in the field, especially at the front desk. You as the front office receptionist or the medical assistant administrator, you will be working very closely with the billing team when it comes to making sure we have the correct insurance entered into the chart, electronic version of the chart, making sure we have the correct member ID and group number, making sure patients' demographics are entered in correctly, and then knowing what the benefits are and knowing what their deductibles, copays, and so forth, those types of things that we'll be discussing. All right, so premium. This is what is paid by the policyholder. The policyholder is also called the insured or the member. So that is the patient who has insurance. They can also be called the subscriber, but under the insurance policy, the policyholder has to pay a monthly fee or a monthly premium. And that amount just states that the insurance company receives the payment for providing insurance coverage. So in exchange for health plan, for the premium that is paid monthly, they then receive benefits. And the benefits are just basically payments from the insurance company for any type of medical services, depending on what is needed by the patient and for a specified time period. Again, depending on what it is. You know, if it's for an office visit, it's just for that office visit. If it's for a hospital visit, then it's going to include the day of admittance to the day of discharge. That's why those dates are so important to document when we are submitting claims to the insurance company. Dependents are people that are insured under the policyholder, under their premium or under their plan. That could be children, it could be spouse. So those are who the dependents are. And then third party is just anybody who agrees to carry the risk of paying for the services provided through the insurance plan. So in a example, that would be, we have a third party called MultiPlan, and MultiPlan just basically agrees to carry the risk of any payments for Blue Cross Blue Shield, Aetna, Cigna, if they're under a MultiPlan, and those companies are just the third party payers. And those again are your health plans. More insurance terminology would be deductibles, and this is just a fixed yearly payment. This is just a fixed dollar amount that has to be paid by the insured or the subscriber for any charges of hospital visits, imaging, laboratory, doctor visits. It has to be paid to a certain amount, and then once that's paid, then the insured is covered at usually 100%. Okay, so a deductible is just a fixed yearly payment. Once that's been met, then typically all they have to do is pay for their copay. Okay, but when they do have a deductible, depending on how much that fixed dollar amount is, all of that has to come out of the patient's pocket until that deductible amount is met. Then you have coinsurance, and some insurances will also, not in addition to having deductibles, will have coinsurances, and those also have to be paid by the patient. And these are just a fixed percentage of covered charges once the deductible has been met. Now, sometimes when it is a coinsurance and they don't just have a deductible, these are like your 80-20 plans or your 90-10 plans or even your 70-30 plans. And what that means is once the deductible's been met, then the insurance agrees to pay at the 90%, and then the patient's only responsible for the 10%. If it's an 80-20 plan, then the insurance pays the 80% and the patient only has to pay the 20%. And that percentage is based on whatever services are provided. So if it is a MRI of the knee and it costs, let's say, $1,000, then after the deductible's been met and there is a coinsurance within the plan, then what happens is the insurance will pay 80% of that $1,000, and then the patient's only responsible for the 20%. So if you do the math, the patient's only paying $200 of that $1,000. The rest is being covered by the insurance. So that's still good depending on what kind of plan you have. So obviously, if you have an 80-20 plan, that's a good plan to have. The best plan to have would be a 90-10 plan where the insurance pays 90% and you're only paying 10. There's also co-payments, and co-payments are basically just a fixed fee collected at the time of the visit. This is if the patient belongs to a managed care health plan, like a health maintenance organization or an HMO. So instead of paying a coinsurance or a deductible, they just have a copay. But you can still have a deductible and or a coinsurance and still have to pay a copay, because once the deductible's been met, then all you're responsible for sometimes is a copay. So it just depends on what plan you have and what your benefits are. Okay, so breaking down elective procedures and then pre-certification versus pre-authorization. A lot of times those two terms are mixed up. So I want to make sure that you guys understand the difference. So when we're talking about elective procedure, that means we know the patient has to have it, so we're planning ahead to perform that procedure. So if we know, as an example, a patient comes in having chest pain, we do a stress test. The stress test says that patient is at risk for a heart attack. There might be some blockage. Then what we do from that point is we plan for the patient to have a cardiac catheterization or an angiogram. So we set it up for maybe a few days in advance or a week in advance. So that is an example of an elective procedure. And that just makes sure that we inform the insurance company or the procedures that are covered by the third-party payers to make sure that one, the procedure is covered, and two, that it does or does not require prior authorization before it's performed. So pre-certifications and prior authorizations will come into play when we are scheduling planned procedures or elective procedures. So pre-certification is the process when we're confirming with the insurance company that the patient's insurance plan does offer coverage for that particular procedure or surgery. Okay, and then once the insurance plan says, yes, that is a covered service, then we have to ask them, is prior authorization required? And this is just a confirmation from the insurance stating that, yes, we're aware that the patient's going to have the procedure. This is a covered service, but we may or may not have to have a authorization number prior to performing the surgery. So some will say if it's medically necessary, go ahead and do it. Some might say this may have to go through utilization review, which means every insurance plan has a medical director as part of their insurance team, and they will take all of those requests for prior authorizations that they feel aren't medically necessary. They will take those to the medical director for utilization review. And if that medical director agrees that it needs to be done, then they'll go ahead and give us the okay to perform the surgery or the procedure, and they'll give us a actual prior authorization number with an expiration date that says you have until this date to do the procedure. If we don't do the procedure or the surgery by that date, we will then have to contact the insurance, let them know, and request another prior authorization number. So the difference between pre-certification and prior authorization is pre-certification is the process of confirming if the insurance company covers that particular surgery or procedure. Prior authorization is being given the okay to proceed. All right, so different types of health plans that we have. All insurance companies have their own rules and benefits as far as it has to do with different types of office visits, procedures, and stuff like that. So we have to make sure that we understand the different benefits about certain procedures or certain coverages by educating ourselves with the different health plans. It's very helpful to have your own login information for each health plan website so that you can log into their website and get information from the provider portal if you have any questions in regards to what is a covered service, what is your contractual rate, because every doctor's office that accepts an insurance plan has had to apply by submitting an application to be able to accept that insurance. So let me give you another example. If I wanted to see patients who had Blue Cross Blue Shield, then I would need to submit an application requesting that I be a covered provider in network to see patients with Blue Cross Blue Shield. So I would be considered what is called a preferred provider. Once that application is processed and approved, then what the insurance company does is they come back to us with a contract stating, we will approve your application for you to be an in-network provider under these agreements, that you are reimbursed at a percentage of whatever the cost of the procedure or office visit is. And if the provider agrees to that, then we proceed with signing the contract, and then we can start seeing patients covered under Blue Cross Blue Shield or whatever insurance plan that we've applied for. We can't submit claims for reimbursement to any insurance company until we have been approved to be within their network. If we're out of network, we can submit claims for payment, but what happens is the patient ends up paying for probably 80% of the fees, and then the insurance will pay little to nothing for the reimbursement. So that's why it's important for providers to make sure that they're contracted with these different insurance companies, because they want to ensure the highest possibility of reimbursement as much as possible. So how do we know what we are reimbursing for? What are our charges? Well, we do that based off of a fee schedule. And a fee schedule basically just explains what our usual fees are what we charge the patient most of the time, depending on normal circumstances. And then we list those on a fee schedule. And the fee schedule can look something similar to this. Let me pull one up for you. All right, so there's one that's Blue Cross Blue Shield. And basically what it does is oops, sorry. Let me pull this up a little bit bigger. What we do is we create a form, usually on an Excel. I created mine all on an Excel when I worked in the doctor's office. And I listed it by the procedure. But what I did is I listed it by the CPT code and then the description. So if a 99201 was considered a new patient level 1 or very basic office visit, that a 201 is typically the non-physician office visit, meaning the patient just saw the nurse or something like that. Then what I would do is give the description, and then I list the amount that we would charge if we were charging the patient out of pocket, meaning patient didn't have insurance, they were just paying out of pocket with cash. And then I would have in the next column Medicare's allowable fee, what Medicare says we can charge. And then what I would have is what our fee schedule is based on Medicare's allowable, because we can submit for reimbursement up to 200% of Medicare's allowable. And that's what we typically issue to the insurance company. So this is an example of Blue Cross Blue Shield's fee schedule, and this is what they're telling us. You guys probably noticed this 99386. You guys remember what that is? That's the office visit with the mammogram screening, right? So Blue Cross Blue Shield Medicare Advantage plan says the allowable amount to submit for reimbursement, let's go over here to 2019, as of July 2019 is $164.85. Now you can see it's inflated since 2018, and then in 2018 it inflated from 2017, and it only went up a little over $1 here from 17 to 18, but then from 2018 to 2019 it went up just a few more dollars, but less than $10. So as you can see, it's very difficult for providers to really sustain a successful practice when it comes to trying to get reimbursed by these insurance companies, because they pay very little when it comes to reimbursement. So sometimes it can be a little frustrating. Now here is a doctor's office fee schedule, and this looks like very similar to how I would create mine. I would have the CPT code and then the description, and here you see the code for Urinalysis dipstick is $4 for non-facility global fee. So this means this, it was probably done in the laboratory. If it was in the facility, it would probably be a little bit extra, because we have to keep into consideration the supplies that we have to purchase and needing to be reimbursed for our cost, right? So that's that overhead. So if we have to pay for the dipsticks, if we have to pay for the urine cups, if we have to pay for the machine that reads the urinalysis, then we have to put that all in our cost as a provider. So that might go from $4 up to $14 or $16, because we want to make sure that we're making some of our money back. So anyhow, that is an example of a fee schedule. And then the different health plans that you have two major types of health plans. You have your traditional fee-for-service plans, and then you have your managed care plans. Your fee-for-service plans, probably one of the oldest plans that we have, are the most expensive plans. And basically what this does is you have to pay the practitioner an exact amount for each service that they provide for you based on what the provider's fee schedule is. Okay, so depending on what that fee schedule is, the plan is going to pay back whatever the fee is for the service. So that's probably the closest to being reimbursed for what your fee schedule is. Your book has a really good example of a fee schedule as well that I wasn't able to pull up into the PowerPoint, but it's figure 17.1, and it just shows you the services rendered or the services performed in the office, what the CPT code is, and what the fee is. So that's a really good example of that fee schedule. Capitation has to do with your managed care plans, and they pay the providers that are participating within the plan. So again, these are your contracted providers, and they pay in one of two ways. Again, by either the contracted fees. So if I have a contract and in the contract it says you're agreeing to be paid this percentage amount, or we have fixed payments, which is called a capitation. And these fixed payments, again, are agreed upon, and usually they are not negotiable if it's a capitated rate. The only time that we can renegotiate is when it's a contracted fee. So we typically want to go for the contracted fee versus the capitation plans or the capitation fees, because once it's capitated, it basically, it stays that way. And these are typically more necessary or more common with your primary care providers, because the primary care provider in a HMO plan is considered the gatekeeper. So if the insurance plan says this is your capitated rate, then that's what it is. So, and if you think about the word capitated, that means it's capped off. It's not going to go any higher than that. All right. So, I would say probably, and I think the book also confirms that more than half of the plans are preferred provider organizations, and these are your PPOs, and these are a managed care plan that basically just establishes networks of providers to perform services for those particular plan members. And then basically in exchange, the PPO, for having the PPO, the patients get to go wherever they want. So they don't have to start with the primary care doctor as the gatekeeper. They can go see the cardiologist if they are having chest pain, or they can go to the orthopedic if they're having knee pain or hip pain. They don't have to wait to be referred to a specialist from the primary care doctor. So they get to choose who they want to receive care from, whether it's in network or out of network. But if it's out of network, that out of network provider has to agree to those discounted fees. They can't charge over those fees. If they are in network, then they obviously are going to be paid at the highest percentage for their reimbursement. The most common type of managed care system is your HMO plans, and these are your health maintenance organizations. Again, physicians who are contracted with HMOs often pay at a capitated rate. Sometimes they are employers of the organization, and this would be an example of Banner Network, the Cigna networks, Aetna networks. The most popular are going to be your Banner and Cigna. Banner has facilities all over the valley, and they have their own network. They have their own third-party plan. So how that works is that they become an employer, or excuse me, an employee of the organization, and then they're paid at a specific rate as well. And then another example would be like you have these health organizations around the valley, like Maricopa Integrated Healthcare Services. Those are all employed providers that work for the organization, and they stay within their organization. So if they have to refer out to the specialist, that typically they'll have the specialist within that practice or within that organization, and they stay within their organization because it helps to keep the rates lower. Okay, and most patients or insured covered policyholders have to pay a copay with HMOs, and those can go anywhere from, now I think the lowest copay is $20, and they can go up to $50, $60 depending, because if you go to a specialist, your copay is going to be a little bit higher. And then of course there's copays for urgent care visits that are higher than office visits, and then your emergency room copays are even higher than the urgent care copays. So typically when you have an HMO plan, you have to choose a specific group that you are allowed to see, and or you have to choose a particular healthcare primary care provider within that or HMO's organization. Okay, so it's almost like the HMOs, think of it as your generic brand sitting on the shelf at Walmart, and your PPO plan is your brand name. Okay, that is the, if you are if you're someone who uses Hunt's tomato sauce, that's your PPO. If you're someone who goes for the cheaper brand and uses the Great Value tomato sauce, that's your HMO. And that's basically how to understand it in a nutshell, of the difference between what's offered and what's not. Okay. Some examples of commercial payers. One of the biggest commercial payers is Blue Cross Blue Shield. They're one of the largest corporations. The Blue Cross Blue Shield is actually nationwide, and they have a federal plan as well. So they have the Blue Cross Blue Shield federal plan, and then of course the nationwide plan as well, depending on who the subscribers are and for what. And then you have private commercial carriers. These are like Aetna, Cigna, and even some of the travelers insurance carriers as well. With the private commercial carriers, they also have, in addition to health insurance, they have liability insurance and disability insurance. Liability is just if a patient gets injured while covered under the insurance, then that injury can be covered as well. They could even possibly get a percentage of their income paid to them if it requires them to take time off of work. So this is just making sure that they're covered for injuries that might have been caused, on a personal level, like a car accident, injured at home. It's just basically a personal injury. Where disability covers is people who are injured or disabled for non-work injuries. So an example of this would be, let's say that I had back surgery, and after the back surgery, I was never really the same. I wasn't able to sit for long periods of time. I wasn't able to stand for long periods of time. So I might have certain coverage for disability insurance that again would help to make sure to pay for my daily expenses as well as pay for my health expenses. So that's the difference between liability insurance and disability insurance. One thing I want to talk kind of in depth about is the patient-centered medical home. And this basically is where we call this the primary care medical home. And this just is basically just an office or a organization that creates a patient-centered facility that allows for us to provide comprehensive care. The services that are included will be not just preventative care, but also treating any acute services or chronic services, and then making sure that the providers have that brick and mortar location or connection to the patient's care. So it could be a combination of telemedicine as well as the patient coming in to be seen. It could be telephone visits as well as the patient needing to come in to be seen, but not as often and not as frequently. So it's really creating that patient-centered relationship between the provider and the patient. And then it's having a patient-centered healthcare team that helps to coordinate the patient's care. If it has to do with skilled nursing facility, patient going to the hospital, if it's home health care, physical therapy, cardiac rehab, anything like that, that would allow for a team of healthcare providers to be involved and make sure that it is patient-centered services that are being provided. Okay, and then the whole purpose of the patient-centered care is to make sure that we are giving out quality care to the patient, as well as making sure that we keep the patient as safe as we can. And the way we do that is provide supporting tools to guide the patient in the medical decision making, and also including the patient's family members or caregivers, whoever that may be. So it's really important to understand what the purpose is of these patient-centered medical facilities, and making it just a more comprehensive care for the patient, making it easier for them to have to go just to one facility, as opposed to having to go this place to this place for one doctor and this place to another doctor, and their doctors are all over the valley or all over the town. If you have it just in one facility, it makes it easier for the patient, and it also makes it easier for the providers involved because it's under one roof, and again, providing that comprehensive care. All right, so let's talk a little bit about government plans now. And the government plans are basically offered healthcare services for either our elderly patients that are over the age of 65, so our retirees, low-income families, and then, of course, our disadvantaged individuals who might be involved with active or retired military personnel, as well as their family. So different government plans are going to include Medicare, Medicaid, which in the state of Arizona is Access. And then you also are going to have your TRICARE and CHAMP VA. So let's just start with Medicare. Medicare Part A coverage is for anything that has to do with inpatient care or around-the-clock bedside care, like skilled nursing facility, the nurse being at the home either around the clock or in shifts, so home health care. Hospice care, again, being round-the-clock bedside care. It could include some mental health services depending on what those services are and what they're being treated for. So it can include some psychiatric treatment. It could include some behavioral health treatment as well, whether it's what we call inpatient or outpatient care. And then it could also include some respite services. And respite services are basically when you have a patient who is terminally ill at the home, and you're just providing some support to the family members that might be the primary caretakers, and they just need a little break. So you might come in for an hour or two to take care of the patient while that family member, steps out of the home, whether just to get a nice, little break or run errands, stuff like that. Part B usually is covered at 80% because these are all of the outpatient services. This is a voluntary program. So if the patient has Medicare Part B coverage, typically the patient's going to be responsible for that other 20%, and Medicare will pay for that 80%. So when it has to do with Medicare Part B, then these are your outpatient hospital services, diagnostic testing, laboratory services, office visits, physical therapy, stuff like that. A lot of times, patients who have Part A benefits will automatically qualify for the Part B benefits. And just so that we understand, Medicare is for our patients who are under the age of 65 or who are dependent widows aged 50 to 65, can be disabled, blind, anybody of any age that might have chronic kidney disease requiring dialysis or end-stage renal disease requiring a transplant. Okay, Medicare is a program that is managed by Center for Medicare Services, and I will just pull up that website for you real quick so you can see it. And the website for that is cms.gov. You guys are welcome to check that out at any time. If you click here on Medicare, it's going to have all this general information, how to submit for an appeal, what their billing process is, any important CMS forms, Medicare Advantage. These are your Medicare Advantage are for your patients who typically want to have more than just Medicare coverage. It'll have prescription drug coverage as well. And then here's the fee for service for Medicare Part B medications or drugs. And then here you'll see Medicare fee for service payment. Here's the fee schedules. This is just general information on the fee schedules based on zip codes, or here is the end of year for 2019. This is a zip file, which means it's very large, so we're not going to open that, but feel free to glance around in this website. It's really informative. But that is that is who basically manages and maintains both Medicare and Medicaid. Okay. Part C is basically very similar to managed care options, or like your PPOs or HMOs or your fee-for-service options, very similar to the commercial plan payers. Medicare Part D is just for prescription drug plans. This offers a little bit more coverage for prescription drugs for the patients that have high cost of prescription payout fees, and they might need a little bit more support. Okay. Recovery audit contractor program basically is just new steps that help to prevent insurance fraud or insurance abuse with Medicare. Because Medicare is such a great reimbursement when it comes to them paying back their claims quickly and very close to the amount that you charge. Sometimes, unfortunately, doctors will take advantage of that and try to make more money because they know Medicare is good at paying back right away. So they will abuse or commit fraud with Medicare, and that's a big no-no. But the RAC program is just there to make sure that that is being prevented at all costs, doing audits, stuff like that, making sure you're submitting the meaningful use codes so that you are following all the guidelines to make sure that none of that insurance fraud or abuse is being performed. Okay. Medicaid is just your government plan that is for people who are low income or have any type of disability. So these are for your disabled patients. It could also be for foster children or children that are born with birth defects and may need a high cost of coverage. You have to understand that Medicaid is a health cost assistance program. It is not an insurance program. It is nothing similar to these commercial plans or these private payer plans. The government does provide these health cost assistance to the patient at no charge, or depending on the patient's income levels, sometimes there can be a very small premium that has to be paid, but it's something like $20 to $25 a month. Very, very cheap in that sense, because obviously it's designed to help low income families. Every state in the United States has their own program to assist with health cost. So you have to make sure that you understand each state's government program assistance, depending on what their qualifications are. So depending on what it is, you'll know what the coverages are. Like here in the state of Arizona, coverages are for children for including medical, dental, and vision up to the age of 21. Once they hit 21, they are no longer covered under vision or dental. They have to then apply for Medicare, or excuse me, I'm sorry, they have to apply for just the medical coverage, and that's all that they'll receive. They no longer will be covered under dental or vision. Most of these cost care containment assistant programs were designed for children, and then of course for adults who couldn't afford based on their income qualifications, and then also for any of our disabled patients as well. TRICARE and CHAMP VA is specific to our military. So this is, TRICARE is run by the Defense Department. TRICARE used to be known as Civilian Health and Medical Program for uniform services, and uniform services were our military, okay? It used to be called CHAMPUS, and that's why that was the acronym, Civilian Health and Medical Program for Uniform Services. These are not insurance plans. Once again, these are more just healthcare benefits for the military. So for the person that is active in the military and their families. And then of course, once they become retired military, then they go in from a TRICARE to a CHAMP VA. So TRICARE Prime is basically like an HMO, where TRICARE Extra is like your PPO plan. And then you have TRICARE Standard, that is like the fee-for-services. TRICARE for Life is more for the Medicare eligible military retirees and their family members. So when you see TRICARE for Life, these are your 65 and older Medicare patients or Medicare qualified patients. So it's very similar to Medicare, but it's through the, again, through the government for the Defense Department. CHAMP VA, let me just switch over. Oh, it's missing on here. Sorry about that. I'll just talk about it. So CHAMP VA is the acronym for Civilian Health and Medicare Program of the Veterans Administration. And again, this covers the expenses of the families, their dependent spouses and children, for anybody, for any veteran that has service-connected disabilities. So if they were hurt in the line of duty, then they would be covered under CHAMP VA, and also their families would be too. So that would be spouse and children, okay? So depending on the eligibility, it just depends on them enrolling in the Defense Enrollment Eligibility System. And then the eligibility is then determined by CHAMP VA, depending on the closest Veterans Affairs Medical Center closest to them. Here in the Valley, we have the one downtown Phoenix. We also have now one in the West Valley off of Grand Avenue. And we also have one in now the East Valley off of the 202 and Pecos Road. So a lot easier for veterans to receive care, but still a little difficult when it comes to getting in a lot sooner than if you were to a regular doctor. Okay, so payer payment systems. These are your resource-based relative value scales, and this is based off of Medicare's payment system. So basically, it's just a formula. They take the relative value unit, it's multiplied by the geographic adjustment factor, and then a conversion factor is applied to the cost of living. And basically, what that means is your RVU, or your relative value, is based on three cost elements: the physician's work, the practice cost overhead, and then the cost of any malpractice insurance for the provider. Then your geographic adjustment factor is used to adjust each of your RVUs, or your relative value, basically reflecting that of the geographic area as far as office rent and utilities. So depending on where the office is at and what the going rate is for rent and utilities, they base it off of that. They don't base it off of what you pay, they base it off of the geographical area. And then so your conversion factor is basically a dollar amount used to multiply the RVU to produce that payment amount, and that is how Medicare figures out what their reimbursement rate is. Okay, so this is when we use the RVS, it is basically used when your providers receive a large amount of lower payments than usual. So it makes sure that they get that reimbursement back as much as they can for any services that they provide or any services that are rendered to the patient. So different types of payment methods. Most third-party payers use allowed charges, again, the contracted fee schedule, or the capitation rate. So it's per member per month when it comes to the capitation rate, just depending on the services provided or what initiates the contract with the providers. These are more your preventative care, child checks, your monthly women checks, the gynecological exams, your eye exams, your hearing exams. These are things that are done more annually than they are as, you know, like if we wanted to do them anytime we wanted to. So how do we calculate patient charges? Well, that's going to include the patient's deductible, co-payment, co-insurance, and then we just basically figure out what the charges are. If the charges, an example would be if a patient had a nuclear stress test and we charged $900 for the nuclear stress test, and let's say the patient had a deductible of $1,000, then only $200 of that have been met. So basically what we would do is if $200 of that has been met, then we are going to charge the patient for the $900 nuclear test fee. And then the insurance will now be covered if they have an 80/20 plan or covered at 100%, depending. So their deductible's been met for the year. So everything's going to be covered either at the 100% or at the 80/20, depending on what their plan is. But what happens is the insurance company then receives our claim and they see that the deductible's been met. So they'll take that 200 that had been met prior to, and they will subtract that 700, right, from the nuclear stress test that they paid for, and they will reimburse that to the patient, the $200, because if they paid $900 for the test and we submitted the claim to the insurance company, then the insurance company is going to require us to reimburse the patient the coverage and the overage that they paid. So now we have to submit a refund to the patient, and then the insurance will cover that 80%. So sometimes when we collect up front, it does end up being that we have to provide refunds. But how I've taught my billing team in the field is that it's easier to have to submit a refund than it is to have to collect on an invoice or on a billing statement, because patients will try to avoid paying their bills. So I would rather collect up front and have to owe a patient than not collect up front and try for the next 90 days trying to get a payment. So just depending on what is being provided as far as services, that's how we will calculate what the patient's charges are. Whatever the charges left over that the insurance doesn't pay, that's what's billed to the patient. But we can do an estimate prior to services rendered, and then, like I said, just issue a refund at the end. So it's really on whatever your policy is and however you want to set that up. Some offices say no, just bill the patient later. Some offices say no, let's collect ahead of time, and whatever the insurance comes back and pays, if it's the same of what we collect from the patient, then we will be happy to issue the patient a refund. Okay. When it comes to communicating with patients about charges that are not covered, you always want to make sure that you have the patient sign what's called an advanced beneficiary notice of non-coverage. And this just basically states to the patient that if this ends up being a non-covered procedure or office visit with your insurance company, then basically the patient is responsible. And you want to communicate that ahead of time, not after the fact, because the patient can come back and say, well, you didn't say that if the insurance didn't pay that you would charge me. So it's always important to make sure that they understand, should the insurance not cover, you will be responsible if you want to proceed with the procedure. And that's what the ABN is for, and is very helpful in that case. All right. So when we are processing a claim, we want to make sure that we have this basic information of the patient. And again, as the medical administrative assistant checking in the patient, it's very important that you get the demographics entered in correctly. So name exactly how it appears on their insurance card, not their photo ID. Address, phone number, date of birth, social security, entering the member ID number and the group ID number correctly, because this, if not entered in correctly, can slow down the claims process and can definitely slow down the reimbursement process. We want to make sure that we are checking ahead of time what the patient's eligibility for services are, and if a prior authorization is needed, that we're checking that before the services are rendered. When it comes to coordination of benefits, we use what's called the birthday rule. Sometimes patients will have more than one insurance plan. They will have a primary insurance and a secondary insurance. And the birthday rule has to do with when there are dependents on these insurance plans, and both the wife and the husband have insurance. So you have a primary plan and a secondary plan, but how do you figure out who's the primary and who's the secondary? Well, we use the birthday rule. And an example of this is if the husband's birthday is July 14th and his wife's is June 11th, following the birthday rule, the wife's insurance plan becomes the primary insurance, and then the husband's insurance plan becomes the secondary insurance for their dependents. So it's whoever is older is the primary insurance, and then the secondary insurance is that birthday rule. So this would pertain to their dependents, not to themselves, of course. All right. making sure that when we're delivering services to the patient that we are explaining what the practitioner services are, that the practitioner is licensed, who is going to perform the procedure, making sure we're documenting in a progress note everything that was done, and then making sure that we indicate on a super bill the medical coding. So that's including the diagnosis code and the procedure code. Remember, I talked last night for code linkage, you need to make sure that you have a CPT code, a diagnosis code for every CPT code, okay? Then again, making sure you've got any referrals if the patient's an HMO and they have to see their primary care doctor first. A paper referral is required for them to go to the specialist. That has to be documented. And of course, authorizations as well have to be documented. We have certain electronic claims transmissions that are mandated by Medicare. We have to make sure that when we're preparing the electronic claims that we're preparing them precisely, everything is entered in correctly, that we're using a clearinghouse to kind of be our filter. And if things are not correct, it will kick them back to us and send errors and tell us to fix it so that we can then enter it in correctly and submit it out to the third-party payers. So our clearinghouse is kind of like our in-between man that makes sure everything looks clean before we send it out to the insurance company. If we're not sending an electronic form, then we would just fill out a paper claim, and that paper claim is the CMS 1500 form, and that looks like this. Oops. Sorry, hold on. All right. This is basically what is called your HCPCS form. Let's see. And that's what this looks like. It's very similar to your insurance form, your 1040 form. You have to fill out every box, and every box has a letter and a number associated to it. And you have to make sure that it's all filled out completely. If it doesn't pertain, you have to put an NA or does not, not applicable, because if it's left blank, they're going to assume that you forgot to fill it out. Okay, so again, when we're transmitting the claims, we're using a clearinghouse as our in-between or our filter to make sure that we are submitting clean claims, making sure that if there's any errors, that we're fixing the errors before we're submitting them to the insurance company. Okay, and that is making sure that we're generating those clean claims. And then claim security is just basically computer networks, which we have connected to our personal computers through a local area network. And they basically just provide any information that would make sure that we can submit those claims directly from our system to the insurance plan's system, or directly to their network. You always have to make sure it goes through a firewall or some type of security device, because it does have personal health information. And of course, according to HIPAA standards, we want to make sure that we're protecting all patients' PHI, even when transmitting electronic claims. So it's really important to have that claim security. Okay. Insurer processing claims and payments. The claim register is just basically transmitted electronically. Again, it's through the billing program or the clearinghouse. They will create a log of claims to allow you to track the progress of the claims that you've submitted, just to see if they've been received, if they're being worked on, or if they've been rejected or denied, that type of thing. When we review for medical necessity, we're making sure that each claim is reviewed to determine whether or not the procedure provided did accompany a diagnosis that is compatible with the procedure. When we are reviewing for allowable benefits, this is just comparing the fees the provider has charged with the benefits provided by the patient's health insurance policy. So making sure that these benefits are allowed, okay? That plays in with the role of getting that pre-certification or prior authorization. And then your payment or your remittance advice, basically this is just the explanation of what was remitted, so what we did, and what was remitted as far as payment. When the payment, with the payment, the insurance company will send a remittance advice or an explanation of payments or sometimes called explanation of benefits. And this is just a breakdown of when the patient was seen, the CPT code, description of it, what the allowable charges are, what the insurance will be allowed to pay, what they've paid, and then what the patient will be responsible for. These explanation of benefits or explanation of payments are not statements. They are not invoices. We cannot bill the patient with these. We are just being told how much the insurance is paying for the services, and then we can take that and determine after what the insurance has paid, whatever's left over will be what the patient is responsible for. So that basically ends the process of processing claims. And please don't think that you have to know how to do this. This is just you having a general understanding of what this is and how it's done, in the important role of you making sure that you have all the correct demographic information in, as well as the insurance information. Because if we have to go back and correct that because the clearinghouse kicks it back and says there's errors, spelling of the name, wrong date of birth, wrong ID number, that just slows down the claims process, and it ultimately slows down the reimbursement process. So the quicker we can get those claims out, the quicker we can get paid, and that benefits the practice as a whole. So that wraps up Chapter 17's, that wraps up Chapter 17's lecture. If you have any questions, please make sure to contact me, and we will basically go from there. You guys have a great evening. It is Thursday, so enjoy your weekend, and we will see you back on Monday. Take care. Bye-bye.